Welcome to Clinical Capsules from TRC Healthcare, your go-to podcast for fast, evidence-based insights. On this episode, Associate Editor and Clinical Pharmacist Vickie Danaher spotlights Suzetrigine, Journavx, the first in a new class of non-opioid analgesics, and breaks down what you need to know before recommending it for acute pain, in an excerpt from our popular Pharmacy Essential Updates webinar series. TRC has been a trusted resource for healthcare professionals for over 40 years. And now we're bringing that expertise straight to your ears every second and fourth Tuesday in bite-sized, actionable episodes, right here on Clinical Capsules. Let's take a closer look.
And our article says the spotlight is on Suzetrigine, or Journavx, as the first med in a new class of non-opioid analgesics approved in over 2 decades. And given all the ongoing concerns with opioids, such as the risk of misuse or developing opioid use disorder, I think it makes sense that Suzetrigine is getting a lot of attention as a potential alternative for managing pain. So today we're going to talk about the efficacy and safety of Suzetrigine, its role in therapy, and what we need to watch out for if patients get this medication. So like I mentioned, Suzetrigine has a different mechanism of action than opioids, which we know block pain by binding to opioid receptors, mainly in the brain and spinal cord, and also by releasing dopamine, which leads to feelings of euphoria. Suzetrigine, on the other hand, is a selective sodium channel blocker. And it works by inhibiting a specific sodium channel in the body called NaV1.8, which is involved in transmitting pain signals from the site of injury or inflammation to the brain. So by blocking the NaV1.8 sodium channel, Suzetrigine prevents pain signals in the peripheral nervous system from reaching the brain in the first place. And because Suzetrigine acts outside of the central nervous system and it doesn't affect the brain directly, it doesn't have the risks and side effects associated with opioids, such as drowsiness, respiratory depression, or the potential for abuse or misuse. And Suzetrigine is also not a controlled substance. But how well does Suzetrigine work? Based on clinical studies, you'll hear that Suzetrigine reduces moderate to severe acute pain better and faster than placebo. And it also works similar to hydrocodone acetaminophen. But keep in mind that these data are mainly in about 900 patients receiving Suzetrigine after a tummy tuck or bunion removal. And about 85% or more of the participants in these studies were white women with an average age in their 40s. So this is a pretty specific group of patients. Explain it's too soon to say how well Suzetrigine works in a broader, more diverse patient population. It's also too soon to say if Suzetrigine works for other types of pain, such as chronic pain or nerve pain, although trials are investigating its use for these conditions. There's also some other limitations and downsides to be aware of. For example, these trials of Suzetrigine allowed taking ibuprofen as needed as a rescue medication. The data on how many participants took ibuprofen are not yet reported. So that makes it difficult to determine how much of the effect may be due to the rescue treatment versus Suzetrigine itself. The trials also aren't formally published in a peer-reviewed journal yet, so for now we're relying on the information from product labeling and the manufacturer website. In addition, the studies use doses of hydrocodone acetaminophen that are lower than what's often given post-op. And it was dosed every 6 hours, which is less frequent than the Q4 to 6 interval that many patients would take after surgery. Plus, another potential big limitation is cost, since Suzetrigine costs about $15 per tablet. So anticipate payer rejects or prior auths, and overall, don't jump to Suzetrigine for moderate to severe acute pain. Instead, continue to reassure patients that oral acetaminophen or an NSAID, such as ibuprofen, is usually effective for acute pain. I recommend either one of these medications first, or the combination of acetaminophen and an NSAID if needed. So for example, we can suggest acetaminophen 500 to 1,000 milligrams and ibuprofen 200 to 400 milligrams every 6 hours as needed. Explain that the combination seems to work better than either med alone, and doses can be taken at the same time. And then we can consider suzetrigine as an option for managing acute pain if acetaminophen and an NSAID isn't enough, or if these meds can't be used, as well as if patients can afford suzetrigine's cost. It may also be suitable in patients with risks for abuse or misuse, or patients with opioid use disorder, although it was not specifically studied in these patients. And then if patients get suzetrigine, we'll need to take steps to ensure it's used appropriately. So watch dosing closely and educate patients about proper administration, since this can be a little confusing. So most patients getting suzetrigine should start with two 50-milligram tablets or 100 milligrams by mouth on an empty stomach first as a loading dose. And then starting 12 hours later, patients should take one 50-milligram tablet every 12 hours thereafter. And these doses can be taken with or without food. But again, the loading dose needs to be taken on an empty stomach, so at least 1 hour before or 2 hours after food, to ensure optimal absorption and to avoid any delay in the onset of action. Also, keep in mind that dose adjustments are needed in moderate liver disease, and suzetrigine should be avoided in severe liver disease. Also, stay alert for interactions. For instance, avoid suzetrigine with strong CYP3A inhibitors such as itraconazole or inducers such as rifampin. Educate to avoid grapefruit, and also ensure that an avoid grapefruit auxiliary label is included with suzetrigine prescriptions, since grapefruit can increase suzetrigine levels. Also, check if patients getting suzetrigine take hormonal contraceptives. Suzetrigine may decrease the effect of certain progestin hormones, since progestins are CYP3A substrates, and suzetrigine is a CYP3A inducer. Recommend backup contraception, such as condoms, while on suzetrigine and for 28 days after. In patients who take hormonal contraceptives that contain progestins other than levonorgestrel or norethindrone. Studies suggest suzetrigine has a minimal effect on combination ethinyl estradiol with levonorgestrel, but it may affect other combinations. So this is a good reminder to make sure patient profiles are up to date with current meds when dispensing suzetrigine to catch potential interactions. Another thing to stay alert for are look-alike, sound-alike errors. So I know when I first saw the brand name Journavx, the first few letters reminded me of Jornay PM for ADHD, especially if it's abbreviated as Jornay. Suzetrigine can also be confused with lamotrigine since they end in the same 7 letters and they both come in a 50-milligram strength. Let patients know about side effects. The most common ones with suzetrigine include itching and muscle spasms. And advise limiting treatment with suzetrigine to the shortest duration needed. There are no data for its use in acute pain beyond 14 days. So watch for suzetrigine prescriptions with refills or more than a 14-day supply, and stay alert for refill requests. And finally, there's a couple special considerations relating to suzetrigine's use in the hospital that are worth mentioning. In most cases, we shouldn't expect suzetrigine to be added to formulary, again, mainly due to cost. It's about $15 per tablet, so that's $30 per day. But you might see some uptake if suzetrigine gets added to the Non-Opioids Prevent Addiction in the Nation Act, or No Pain Act. This would require Medicare to provide additional reimbursement for suzetrigine in hospital outpatient departments and ambulatory care surgery centers. Also, be aware that some inpatient pharmacies may receive an initial supply of brand name suzetrigine as part of a manufacturer pilot program that provides enough med to treat up to 100 patients for 5 days. If your hospital participates in this pilot, Make sure that the meds provided are only dispensed to inpatients, not patients being discharged. So, to close out this topic, be sure to get our Suzetrigine quick skim graphic on our website to share fast facts about this new medication. And also review our resource, Analgesics for Acute Pain in Adults, to compare Suzetrigine to other medications.
We hope you enjoyed and gained practical insights from listening to this episode. We've linked the resources we mentioned and more on today's topic right in the show notes. Those links will take you straight to Pharmacist Letter, Pharmacy Technician's Letter, or Prescriber Insights, where you'll find even more concise, evidence-based tools. If you're not yet a subscriber, now's the time. Sign up today to stay ahead with trusted, unbiased insights and continuing education. And as a listener, you can save 10% on a new subscription with code CC1025 at checkout. If this episode was helpful, follow Clinical Capsules and leave a quick rating or review. Tell your friends. Spread the word about our show. Thanks for listening. Stay sharp, stay current, and we'll catch you next time on Clinical Capsules.